Good afternoon, everybody. Thank you for joining us. We still have people going up, so I will speak slowly, and hopefully by the time we start the webinar, everybody will be here who wants to be here. Thank you for joining us this afternoon. Today we're going to talk about treatments for AML. And I'm very lucky to be joined by a couple of panelists who are going to share their perspectives on this. Just to start with, I'm Charlotte. I'm the Patient Advocacy Manager here at Leukaemia Care, and I will be chairing today's webinar. I'm also joined by my colleague Nick, who's going to be helping me. Shall I call you my assistant, Nick? Is that most appropriate?
Absolutely, absolutely.
Thank you.
Good afternoon, everybody. I'm here in assistance. We've got a few connectivity issues, so we'll be candid about that. So rather than hiding in the background, I'm up front in case we lose Charlotte and I suddenly have to appear, so you know I'm here. So ignore me in the meantime if you can.
Thanks, Nick. And on to our panelists then. We're also joined by Karina Emmanouil. Karina, would you mind just introducing yourself for me?
Hi, my name's Karina, and I was diagnosed with AML in March of 2019.
Thanks, Karina. And Manos. You're on mute. Manos, you're on mute. We can't hear you.
Well, good evening, everybody. Hello?
Yeah, we can hear you now. Perfect.
Can you hear me now?
Yeah.
Welcome, everybody, to this webinar. I'm Emmanouil Nikolousis, one of the consultant hematologists that used to work in the West Midlands, now working in Clatterbridge.
Thank you. We're going to kick off today's webinar with a short presentation from Manos. He's going to talk us through sort of the landscape of AML now. So Manos, do you want to share your screen when you're ready? Oh, has he frozen? We'll see if he comes back for a moment. That's a good start, isn't it? While we're waiting for Manos to come back, I'm thinking, Karina, sorry to put you on the spot, but would you mind chatting a little bit more about your experience with treatments for AML, which treatments you've had and how long they took and those sorts of things for us?
Thanks, Charlotte. So after my diagnosis in March, I was given 3 rounds of the standard intensive chemotherapy, which I had in hospital. And unfortunately, I wasn't able to have a stem cell transplant as that fell through last minute. And then I was actually offered and was on for 12 months a new targeted therapy regime. So I've had an experience of the standard chemotherapy as well as one of the new treatments that are coming through.
Great, thank you. And the first treatment you had, if you don't mind me asking, what the chemotherapy treatments, what happened with those? I'm assuming they didn't quite work in the way that was expected, and that's what led to the other treatments.
Yes, that's correct. So I had the first 2 rounds of intensive chemotherapy, and I was still, unfortunately, MRD positive after those 2 rounds. So then I was given a further higher dose of chemotherapy called FLAG-IDA. So after that, I would need a stem cell transplant. My sister was flown over from Australia as my haplo match. But unfortunately, 2 weeks before the transplant was due, my antibodies flared up in my blood and we became incompatible. So unfortunately, with my rare tissue type, there is a very slim chance of finding an alternative donor, which then led to me being offered this new targeted therapy regime to see if we could get me into MRD negative. And I stayed on that regime for 12 months because I responded so well to it.
Forgot to unmute there. I'm doing it now. It's great that you're currently in remission. It's really good to hear. And we'll come back later to hearing a little bit more about the difference between chemo and other things. Nick?
Would you find it easier if I tried to share Manos' slides? I found Manos' slides. That might actually give him more communication capacity, yeah? Yeah,
better bandwidth. Yeah, please share Manos' slides, and then Manos, I'll let you carry on with the presentation. Sorry we lost you there. Just while we're waiting for the slides, I forgot to say at the beginning, if anybody wants to ask questions, we won't be allowing you to unmute yourself or anything like that today. If you did want to ask questions, please use the chat function instead, which you can usually find at the bottom of the screen with a little speech bubble. So we'll be monitoring those and we'll try and answer all your questions towards the end of the webinar. But Manos, please.
So thank you very much. And I think it's very exciting these days talking about the acute myeloid leukemia treatments and looking at what we have had all these years. I mean, we know that acute myeloid leukemia is a very, very difficult disease to treat. It's a life-threatening disorder. And there are many patients who went through many different treatments. And it's always sort of good to hear from patients like Corina, for example, the experience that they had through the treatment of AML. And certainly from the clinician's perspective, is when you deal with patients with AML, you don't really deal with a very small group of patients that are confined to a certain age group. We know that AML usually happens more in patients above the age of 70. However, Corina is very young. And you can see that Corina is actually having AML despite being so young. So it can happen to all the people. And I think it's very important for clinicians, but also in the primary care, to have the right diagnosis first. We think about how AMLs are. We might say, yes, everybody who has AML, they think it's the same disorder. It is not, because obviously there are different risks there. And Corina mentioned earlier about the stem cell transplant. And obviously that was the case because the disease was quite aggressive. Not all the AMLs need a transplant. And that's why it came the idea about how we treat the AMLs in different ways that the patients will benefit more from the treatment from AML. But we have to think that these treatments that we give, they're chemotherapy treatments. And we know that chemotherapy sometimes can be very toxic for the patients. And when it's toxic, we really need to get the level right. We need to get the level of efficacy right. But what we don't want is we don't want the patient to suffer more from the treatment than from the disease, and actually keep the balance right in a way that we will aim for cure for some patients. For some other patients, we will aim to prolong survival, but at the same time, it's not about prolonging survival by a patient staying in hospital. It's about thinking about the quality of life for this patient. And that's why nowadays we have 3 different distinct groups of AML, if we think about the risk of AML for the patients. Number 1, we have the favorable risk group. And this is something that has been established by the European Leukemia Net group, and actually has classified the AMLs into 3 groups: the favorable group, the intermediate group, and the adverse group. And in general, within the favorable group, Corina mentioned earlier about transplant, and you will see that in this favorable group, very rarely you will see transplant patients with AML. So it's about 15 to 20% of patients in the favorable group that will have a stem cell transplant. And then we go to the intermediate group, and you can see that there are different numbers there and different names. And all these number and names, they do refer to chromosomal abnormalities, because we know that AML can come as a surrogate thing with the molecular markers that can affect the molecular mutations, can drive the process in the bone marrow of all the patients. But also within the chromosomes, they give us a good idea about how good or how badly this AML will behave. And the intermediate group is something between the favorable and the adverse. And some patients might have a transplant or might not have a transplant, depending on specific sort of treatment targets and treatment goals. But the adverse group, if somebody is up to the age of 75, I would say, in most of the units, but also at the same time being fit enough, not having comorbidities, having tolerated the chemotherapy treatment well, if they have a donor, or if there is an alternative donor like a core transplant or a haplotransplant, as Corina mentioned, then you can actually go for the allogenic stem cell transplant, because the adverse risk group, the prognosis of AML without a transplant is very, very dismal. Next slide, please. So I think along with the advances of how we interpret the AMLs, how we actually think, how different are the AMLs in between patients, we also have advances in the AML therapies based on the different groups, the different pathophysiological groups, so how the disease develops in the bone marrow. And we do have the genetic targeted therapies. And that's because now what we know about AML is we know very well about the different mutations that we have in AML. And this is very important about trying to target these mutations. But also sometimes what we have, and that was driven initially by the lymphoma treatment. So some of you might have heard a drug called Ritoximab, which is a monoclonal antibody. It's an anti-CD20 that has been used in the lymphoma patients. So this was like a monoclonal antibody that can recognize some proteins on the surface of the cancer cells and can act like a key with a key lock, which will actually lock to the cell surface of the cell and will completely destroy the cancer cell. And of course, sometimes you have other treatments like venetoclax or Glatexgib, which have been developed recently. There are small molecules that they actually drive different sort of pathways within the formation of the leukemic stem cells. Next cell, please, Nick. So why the different sort of the different risk groups are important? And in fact, what you see there is the survival. How many patients are actually still alive? And on the top, on the A, is patients less than 60 years old. On the bottom, the B, is patients more than 60 years old. And have a look how different these survival curves look like. Because on the top one, less than 60, you can see that there are some specific leukemias, and also based on the different age groups, the different years as well, when you give the treatment, that the patients can actually do better or worse based on the age. So patients who are older, they tend to do worse. And patients who are younger than less than the age of 60, they tend to have a better survival. And this is for many reasons. One of them, there is a gene called the multi-drug resistance gene that patients above the age of 60 do express more than younger patients. And this multi-drug resistant gene is a gene that these awful leukemic cells develop and they get resistant to treatment. And that's why patients relapse or patients are refractory to treatment. So patients who are less than 60, this expression of this gene is significantly lower. But also with the new molecular markers, we know that older patients do express more of the bad risk molecular mutations. And that's why it's more difficult to actually intervene too much with the outcomes, because some of these mutations might have come from an underlying myelodysplastic syndrome that develops very, very slowly and practically might not give any symptoms to the patients. But actually, when it develops to AML, it's a completely different story. And that's why it's more difficult to treat, because it's a secondary AML. It's a different type of AML that develops from a previous condition. Next slide, please, Nick. So I think the recognition recently, one of the main breakthroughs in the treatment of AML is the specific mutations. There are the recognitions of the specific mutations as a genetic driver, so facilitators of AML, have led to the developments of the inhibitors. And I think obviously Corinna has mentioned earlier about this inhibitor that's like this maintenance treatment. And this is something to suppress this particular mutation over a period of 12 months or even longer in some of the patients. So certainly we have more and more of these drugs coming up. Before, it was mainly about throwing in all the toxic chemotherapy, throwing all the nuclear bombs to kill everything. However, now it's a little bit more selective. So we try to actually target what's causing the leukemia. And sometimes it's very successful. Corinna is, the example. Some other times, because there are other mutations as well that we haven't identified as yet, and they might not be affected by the treatment, then it might not work as well as we would expect. But that's why we need a very careful monitoring. And I'll tell you how, at the end, how we do monitor the AMLs those days. Next slide, please. So I'm just giving you some mutations here, which along with the FLT3 and the NPM1. So the FLT3 and the NPM1 have been mutations that have been identified more than 10 years now. And we know that sometimes actually it does have a significant prognosis impact on the patient. So the NPM1 on its own is a good mutation, and it can actually have some survival advantage, whereas patients who have the FLT3 mutation, then this is poorer risk group. Of course, it depends on the size of the mutation and the quantity and the actual allelic ratio of the mutation of the FLT3. And this can actually lead to the physician to decide whether this patient, if they have a donor, will go down the stem cell transplant route. And you can see a few of them there, that some of them do have an inhibitor. So for example, IDH1, IDH2, at the moment there are inhibitors against these mutations. And there are inhibitors that can work quite well with these mutations. FLT3 is the same. And in fact, FLT3 has more than one drug that has been found to be successful against a FLT3 mutation. But some of the others that you see at the bottom, like the NRAS, the KRAS, the RUNX1, the TET2, they don't have any inhibitors at the moment that have been found to inhibit this particular molecular mutation. Next one, Nick. Thank you. So as you can see there, there are some things that are very important. In the 1970s, we used to give the high dose chemotherapy, and that was it. 1970 to 1990, the only thing that happened in 20 years, you have another drug there called idarubicin, which is more or less the same like daunorubicin, but the second drug that has been approved within 20 years. Then in 2000, the gemtuzumab osagamycin, which is a so-called Mylotarg, which is a monoclonal antibody, an anti-CD33 monoclonal antibody, has received approval in the US. So 30 years without a targeted drug. So you can imagine that this 30 years was a very difficult time. You are treating all these patients that I've showed you earlier, all the different subgroups with one regimen. So certainly something was not right. And that's why the outcomes have been more dismal. Despite the fact that supportive care has improved, and not only for AMLs, but also for the transplant patients, this was actually one of the things that was lacking. It was a huge unmet need in AMLs, that we didn't have new drugs. We didn't know exactly where AML was coming from. And back in 2010, you can see that gemtuzumab was withdrawn from the market because there were some concerns there about some toxicity of the liver, but then it was put back again in 2017. But I think the most important point is, if you look at it, it's 2017 and 2018, because during that time, there was triple the amount of drugs that has been approved for 40 years before that. So you can imagine suddenly, and that was because of the molecular mutations, because we know how the risk works and how we know how the inhibitors can work. This is where that was very, very important about thinking what's next in AML. Next slide, please, Nick. So that's where you can actually give different treatments for AML and trying to improve the so-called personalized care for patients with AML. So the treatment that Corina had for the AML wouldn't suit somebody else. It suited Corina, and that's why this is like a massive example of personalized care. And you can see that within this group of patients there, you can see that some others, they will have like a core binding factor AML, which is good risk, and they will have like very standard treatment, but they will have, on top of the standard chemotherapy, they will have the monoclonal antibody, the Mylotarg. But some other times you have, for example, the therapy-related AML or secondary AML that will have the new drug called CPX, which is a much more advanced form of chemotherapy, of the chemotherapy that used to give in the 1970s with the DA treatment with daunorubicin and cytarabine. But actually, this is given in a liposomal form that prevents toxicity, because these drugs can have toxicity of the heart. So by giving it in liposomal form, you reduce the toxicity significantly, but also because of its release, it can actually target this awful blast of the AML, and the efficacy for this AML that they have like a secondary AML or therapy-related AML can be significantly improved. Next slide, please, Nick. So what do we think about when we see the patient? We actually think how are we going to improve things? And when we improve things, when we give all these drugs, would it suit everyone? And who is like the most suitable to have the different treatments? Because we can have patients who are above the age of 80, for example, and then you think, well, actually, by giving all this toxic chemotherapy, the only thing that you will achieve is to get this patient in hospital having toxic effects of chemotherapy and potentially die from an infection or potentially die of the complications from chemotherapy. So you have to think in more clever ways to work around. And that's where the current clinical trials are focusing on. And one of the major breakthroughs recently that has been presented on the recent American Society of Hematology meeting was a combination of venetoclax and azacitidine that actually improved significantly the overall survival for patients who are older and would not be able to tolerate intensive chemotherapy. And certainly, there are some patients that will lie somewhere in the middle where it might be for intensive chemotherapy or it might be like for non-intensive chemotherapy. And you actually have to decide, but actually there, what you have to think about is also the risk of the AML and how risky is the AML and how we can try to modify the treatment based on the risk of the AML, but also based on the comorbidities of the patients. And of course, for the younger patients, it's easier because they have more opportunities about treatment. They have different sort of options there. And also we have to, in the back of our minds, in order to cure leukemia, some of them, and especially above the age of 60, a stem cell transplant might be necessary. Next one, please, Nick. So look at how the Americans think about the treatment of AML is different to what we have in the NHS, because obviously the approval process of new drugs is completely different. And I must admit, over the last 5 years, the amount of money has been spent by FDA on novel drugs has been tremendously increased. I think it was about a couple of years ago at ASH when they were presenting some of the health economics about cancer treatment, not only hematology, but in general about the cancer treatment. And in 1975, the average cost of treatment per year for patients were about $127. And now the most recent one back in 2015 was something about $350,000. So you can imagine how much the treatment landscape has changed and how much has been invested into R&D by the bigger companies. And of course, we do have improvements. As clinicians and as patients, we always want to have further improvements. I mean, if we could cure all the patients, that would be probably the happiest moment for us. So if you look at the guidelines, less than 60 in the US is different from above 60. And certainly the less than 60, if they have somebody who has intermediate risk, for example, cytogenetics, and they have the FLT3, which is one of the mutations, they will get the standard chemotherapy along with midostaurin. But then, and the unfavorable risk and the TP53 mutated, there are new sort of clinical trials that are conducted at the moment, because the TP53 is one of the worst mutations that you can actually have in AML. And of course, with the therapy-related AML and the AML that comes from an MDS, we have the liposomal cytarabine and daunorubicin, which, as I say, is the evolution of the treatment that we had back in the 1970s. And it's very helpful in inducing remission for these patients while reducing significantly toxicity. Next slide, please, Nick. Now, in the above 60, you can see that what you have to think is, can we cure the patient? Can we intensify treatment? Or do we want to prolong survival and improve the quality of life? And I think that's where also some of the actionable mutations can be quite significant. In the US, at the moment, Glastonbury is approved, as you can see there, as one of the treatments. But equally, the IDH1 and IDH2 inhibitors have been approved. So that's not something that we do have in the UK, the cytarabine as well. So you can see like different countries, they use different drugs and they try to actually modify the combinations of drugs to fit the patient population. But you can see there, this particular sort of, the three different options there, and individually has about 5 or 6 different drugs each. About 15 years ago, there would have been 2 drugs only. Next slide, please. So I'm giving you some examples of the main regimens that we use now. And one of them is venetoclax and azacitidine for the patients who are older or who are younger. And during the COVID period, we were allowed to use a less toxic combination to try and move patients out of hospital, because we know that as inpatients, the COVID spread was quite high. And I think what we need to think as well is actually by giving all this toxic chemotherapy, even for younger patients, is this the best option? Or if we use a combination where we have more targeted treatment, is actually better. But we have to think in each individual protocols, the stop and goes. And you can see that each one of them. So for this particular one, we have as toxicities myelosuppression, which means reducing, along with the blast cells, it reduces also the good cells that the bone marrow is producing. And of course, something called the tumor lysis syndrome, when all the soulful blasts are killed and try to be excreted from the kidneys, but in fact, because they have toxic substances, they can affect the kidneys if we do not facilitate their excretion from the kidneys. Next slide, Nick. Then we have the new midostaurin, which is a FLT3 inhibitor, along with chemotherapy. And again, this particular one, if you think about what we had before with the other treatment, this one can have a bit more nausea and vomiting and diarrhea, but also it can have cardiac complications or pneumonitis. So if you have somebody who has heart failure, it would be very difficult to give this treatment because it will be impossible to actually try to give to give an anthracycline, to give like the daunorubicin, because it can affect the heart. I mean, one of the side effects is the heart toxicity. Next one, please, Nick. We saw that there is more or less combination of treatment, but actually now with the targeted treatment, we can have single agent treatment. And one of the very good examples is gilteritinib, which is a single agent treatment for the FLT3 mutated AMLs. And gilteritinib targets specifically the FLT3 mutations. There are two main mutations that we look into the patient's sort of DNA. And gilteritinib covers both, whereas there are other, same thing about midostaurin as well, but there are other FLT3 inhibitors like quizartinib that only covers one. So that's where it's very important to get the molecular profile of the patient. And it's very important because we know which drug we can actually use for this patient. It can cover the mutations that we want. But then you see that this one, it's a monotherapy. We know that it's not like chemotherapy, it's like a targeted treatment, but still it can have side effects. And that's very important. So when patients have side effects with the novel treatments, it's very important to contact the local department that's actually treating them. Because that's when we can modify the dose. Sometimes we have to stop the drug for a little bit and restart it. But actually, that's where we have to keep the balance between efficacy and toxicity. And finally, when we use all these novel treatments and now knowing about all the molecular mutations, one of the main things about how we treat the disease, and Corina mentioned that earlier, is the minimal residual disease. And what we mean by minimal residual disease is about detecting one acute myeloid leukemia cell, one blast, within 10,000 or 100,000 cells. So you can imagine how the sensitivity is within these methods. And it can actually bring the best of the knowledge about prognosis, whether we need to intensify treatment, whether we need to give a different drug before intensifying treatment, or whether we have to go to the stem cell transplant. Not all the molecular mutations are good targets for minimal residual disease. So the NPM1 mutation is one of the really sort of good targets for minimal residual disease. Unfortunately, FLT3 isn't. You can detect FLT3 on diagnosis, we can detect FLT3 on relapse, but actually you cannot detect it at the very, very low levels. So if a cell is FLT3 positive, you cannot have the same sensitivity like the NPM1 because FLT3 is a very unstable molecule. So if they try to detect it, it can dissolve and disappear. So I think the MRD, the minimal residual disease analysis, along with the novel treatments, I think is the future in the AML treatment. And I think it can actually turn around the prognosis and the outcomes of the patients, as well as how we process with how we progress our treatments, mainly about intensifying treatment and giving us a better thought about a stem cell transplant, which is a very intensive procedure and does have complications, and giving us the right patients to do it, but also the right tools to monitor the disease, even after an allogeneic stem cell transplant. Thank you very much.
Great, thank you, Manos, for that really thorough presentation. Very, very good. May I ask you one question to kick us off, and the question before I bring Karina back in? You mentioned, I think, a variety of things used to make a choice about a treatment. You've got comorbidities, so other illnesses people have, side effects, genetics. I mean, who's involved in taking all that information and working out what the best course of action is for a patient?
For all the patients, they are discussed in multidisciplinary team meetings. So where all the experts in the myeloid diseases, in AML, are actually sitting together and deciding about what's the best way forward for this patient. I think the treating physician has the overall sort of responsibility of the patient, because they would have seen the patient, hopefully, and I hope that patients do get seen when they get diagnosed, even during COVID, because if we leave them on telephone consultations, I really don't think that's the best way forward for somebody who has a really sort of acute myeloid leukemia. And it's important that the treating physician knows exactly the history of the patient, knows exactly what are the medications that the patient is taking, what's the performance status of the patient, and therefore it actually transmits this information during the multidisciplinary team meeting for the other consultants to have a clear picture about this patient and a clear picture about the treatment.
Great, thank you. And I guess, Karina, I wanted your take on all this as well. I mean, Manos talked a lot there about various different things that come into this decision to treat or not. How was that experience for you? Did you take on all this information, or did you sort of let the team get on with it as such?
Sorry, Charlotte, you did just...
Oh, no. Did I cut out slightly? Yeah. I'll repeat the question if you like. So I was just saying, with all this information that Manos says that they take on board as a team to make a decision about a patient, were you aware of all those things you had that were being taken into consideration, and how did you feel at knowing how complicated it was, I guess?
Sorry, again, you just cut out slightly, but what I got from that was... I mean, firstly, it's fantastic to see so many new treatments become for patients. That's really exciting. And I think your question was that with so many different people involved in the process of the multidisciplinary process of deciding how a patient is treated. What was the next part of that? Sorry, Charlotte, I didn't catch that.
I mean, did you take all that information on board, was the crux of my question, I think.
At the time of my diagnosis and during my treatment, is that what you mean?
Yeah, both, yeah.
Yes, I think with the diagnosis with AML, obviously it's very fast, isn't it? So there isn't a lot of time to take in very much when you first get diagnosed, because it seems like such an emergency. And I pretty much just put it all in the hands of the doctors at the time, because I really didn't know anything about the disease. You know, you couldn't even spell it properly, really. I was quite, it was very new to me. So, but throughout the process, yeah, I felt very much that it was fantastic that there were so many people involved in the decision-making around my treatment plan and the different options that I had. So I really felt that there was a big team behind what was going on for me and how I was going to be treated. So it was very reassuring, actually. Yeah,
that's good to know. We've had quite a few questions come into the chat already, Manos, so I may fire some of these at you. Most of them are quite medical, if that's okay. The first of them is around toxicity of treatment long-term. So you talked quite a lot about sort of the short-term side effects during treatment, but somebody's given an example here of secondary cancer. What do we know about the long-term side effects of AML treatment? And are there any stats on this, is a follow-up question she had.
Okay. Well, Definitely, with all the chemotherapy, when we think about the chemotherapy treatments, there is a risk that they can be a secondary cancer. Now, when we say secondary cancer, we're talking more about myelodysplastic syndromes because of the chemotherapy. And we have seen patients who have been cured from AML, and then 10 years later, they develop a different sort of myelodysplastic syndrome, which is, certainly something worrying. It's not like a massive percentage, but about something between 2 to 3% of the patients will develop like a secondary MDS. Now, regarding the solid organ tumors, it's not so much the chemotherapy. It's if somebody has a stem cell transplant, for example, one of the complications of having a stem cell transplant is secondary malignancy. It's a small percentage, again, something between 5 to 8%, but it can happen after a stem cell transplant. With the current treatments that we have, so far, the only treatment that we know from the smaller molecules that it has some impact on other malignancies is something called ruxolitinib, which is mainly about myelofibrosis. Not anything else, like, for example, if you see daunorubicin, for example, cytarabine, they don't tend to cause any significant sort of solid organ tumors. They can cause some of them, as I say, myelodysplastic syndromes, but not solid organ tumors. I think this should be addressed in the sense of a late effects clinic, and this is usually something that happens post-transplant. And we do have like young patients, like Corinna, having like a treatment. So, for example, Corinna, if she had something different, if she had lymphoma, for example, and she had radiotherapy as well, or she had like a myeloid sarcoma as part of AML, and she had radiotherapy, and she had radiotherapy with the axilla, then the chance of having breast cancer increases significantly. And therefore, you need to have quite thorough monitoring process with mammograms earlier than the usual sort of age of 50, where you will start the mammograms. We tend to start it much earlier on this particular group of patients.
Yeah, I think that's an important point. If anybody isn't getting support for any long-term side effects that you may be experiencing, do reach out for support. There are clinics and things you can go to for that sort of thing. So do reach out for further help on that. The next question we had was about MRD. Someone clearly has been doing a lot of their homework here. They said there's a lot of debate in the literature about whether patients should go into transplant negative, MRD negative, or MRD positive. Does that have an impact on the chances of relapse, or how well their disease is controlled before you go into a transplant?
So, always the disease being controlled before the transplant, having like a very sort of deep CR. So, for example, MRD negative would actually be better. There are some new studies addressing this particular question. So I think one of the things that we have to say is within prospective trials, this is an important question about the MRD positivity pre-transplant. But generally, retrospective studies have said that actually when the MRD is positive pre-transplant and when the MRD is positive in the first sort of 3 months post-transplant, then it is the risk of relapse is higher. But that's where you have to think in a different way. So, for example, what type of conditioning regimen has been used, whether donor lymphocyte infusions have been administered after transplant, if there's MRD positivity, and what's the chimerism of the patient. So how many cells are coming from the donor, how many comes from the recipient after the transplant, and try to actually get all these parameters together in order to decide whether you need to do something before a florid sort of molecular relapse, florid morphological relapse. And if it's still on MRD, with the DLI, there are quite a lot of them that they disappear, the MRD. But I think, as I said, we need more of these prospective trials with the MRD to see whether the MRD is a marker that will affect the outcomes post-transplant. Certainly, patients who are not in complete remission before the transplant, the risk of relapse is significantly higher.
Great, thank you for clearing that up. I think MRD is something everybody is still trying to get used to, these super sensitive tests to detect the very tiny amount of leukemia that's left. We used to base it on different things, didn't we? So thank you for your question, but I think that's the one that needs further exploration by the sound of it. The final question we've got in the chat box so far is a question about relapse. So and the options available at that point. So you named a lot of new treatments in your presentation, Manuel. So I was just wondering if you could sort of specify where in the pathway they tend to be used. The question is, are they available sort of in relapse if people are concerned about that?
Sorry, be available in relapse?
Which of the treatments tend to be more available in relapse?
Okay. So at the moment, when we have patients who have a FLT3 positive relapse, then gilteritinib has been approved for the FLT3 positive relapsed AMLs. And it has been approved as monotherapy because if you compare gilteritinib to standard chemotherapy, the FLAG-IDA chemotherapy, it has shown within a trial called the Admiral trial that has better real results, both in overall survival in patients to be taken to a transplant, and also the time when leukemia comes back. But that's one thing that we have within the relapse setting. Now, all the other drugs, like something like venetoclax or IDH1 or IDH2 inhibitors, at the moment, most of them can be accessed through compassionate access through the drug companies rather than standard sort of NHS funding. Drugs like CPX, for example, the liposomal daunorubicin and cytarabine can only be given in the first line treatment unless there's a clinical trial that you can actually give CPX later. Same thing about Mylotarg. It's usually within the first line treatment. I think it's very simple. Number one, if you look at from the disease perspective, you really want to do anything to get the CR rates better, so the complete remission rates better. Because this way, you can either, if you need to go for a transplant, or you have more chance of being cured. If you think from the pure sort of company perspective, most of the trials are conducted within the first line treatment because some patients with AML, unfortunately, will not be with us, even within the first line treatment. And therefore, there will be a much bigger population to do the clinical trials as well, and more information about the patients.
Yeah, so it sounds as if the best time to give these treatments is at the beginning, and that's why the focus is there. Mm-hmm.
Yeah, I think that's why gilteritinib is the only one that has been approved by NICE to be given for the relapse setting. I think generally the relapse setting in the AML is quite an area of an unmet need, a big area of unmet need. At the moment, there are trials, as I say, with venetoclax in the UK that's being opening up, a trial called Victor. Again, the relapse setting is something that needs more studying in AML, just because I'll say most of the they put quite a lot of weight within the first line treatment.
Yeah. Karina, I wanted to come to you at this point when we're chatting about relapse. As someone who has experienced, the first treatment not working as well, how was that time for you in terms of the emotional impact and things like that?
Yeah, it was completely unexpected. I did have NPM1 mutations, so without a FLT3. So I was given a sort of favourable mutation. So we were initially expecting 4 rounds of chemo. That would probably do the trick, And so after the second round, it really was quite a shock because it just made me really think how much more dangerous the disease had suddenly become for me. Having still an MRD positive, so still some residual cells after the second round. And then after the third round, unfortunately, I was still MRD positive, but very, very low levels. So I have to say it was extremely frightening And also, I just had emotions I'd never felt before that I really can't put into words. And because I'd never been faced with a situation that just seemed really quite bleak at the time. And it was quite terrifying. So yeah, it was hard.
Would help if I muted myself, wouldn't it? I was going to say, would you agree with what Manos said there around the unmet need in that group of patients who relapse from first treatments? So you have access to newer treatment that isn't available standard on the NHS. Would you like to see more of those available? And is it something that is an unmet need?
I think absolutely. I think it seems to be such a complex disease as well. And there are people like myself who have got, initially a very, very good prognosis, and the treatment plan looks fairly straightforward, but something can come completely out of the blue like it did with me. And then again, with the stem cell transplant, my sister was brought over from Australia to be my donor. And then for my antibodies 2 weeks before to flare up like that, and we're suddenly incompatible. It just wasn't even something that had ever crossed our minds. We didn't know that was an option. We just thought she's compatible and that's it. So I do think that it would be fantastic to see more treatments available, even in the first line, and obviously on the NHS, so that more patients can access different treatments for the complexity of this disease and their treatment journeys.
Would you mind expanding a little bit on the difference between your experience on standard chemotherapy and your experience on venetoclax, and as a new inhibitor that's supposed to be more targeted in this sort of thing, it's supposed to be better, in inverted commas. Did you see a difference in how you felt during the two treatment types?
Yes, absolutely. Obviously, with the standard chemotherapy, I had that in hospital and I was in for a month at a time. So over three months of treatment, and with a couple of gaps in between. And obviously the side effects are absolutely brutal. I had very, very high fevers. There's the expected nausea and vomiting. I had awful rashes. I lost the use of my legs. At one point I had tubes coming out of everywhere. It made me incredibly, incredibly unwell. I was in so much pain, physical pain constantly. Just felt like I was bruised all over. And it was very, very difficult being that unwell. And it's difficult for people to understand how unwell those sorts of treatments can make you. Whereas with the venetoclax, I was obviously able to stay home as an outpatient and have this treatment. And I took 6 tablets a day. And I also gave myself injections of low dose RSC, cytarabine. So I was able to do that myself at home and stay at home with my family, which was brilliant. And my hair grew back, which was amazing. And I didn't have the intense nausea and vomiting, which I had with the intensive treatment in hospital. So as long as I kept an eye on my blood counts and just made sure that I wasn't sort of making myself, available to any sorts of infections, I was actually very well. I managed to go on holidays during this time as well. I, could go out for coffee with friends, and, I could be a mother, and, it was fantastic. It was really good. So as the months went on, I sort of did get a little bit slightly unwell from just the amount of chemotherapy I think my body had been through. But it just slowed me down rather than stopping me from doing anything or really, really interfering with my quality of life. So there was a huge difference with that. And also the isolation that you have when you're in hospital. I spent a month not being able to see my children or anybody else, because I was so infectious. So it was a very, very big difference between the two types of treatment.
Hopefully that's something we can see more of in the future. I was going to ask you, Manos, off the back of that, is quality of life and side effects part of what is being explored by researchers in AML, as well as more effective treatments? Is that on the agenda? And if not, do you think it should be?
I think there's no doubt that it should be. The problem is how sort of objective is to manage to actually record the quality of life in different trials. But I think, for example, if you have limited options, for somebody who's like older, let's say, and doesn't have like the same opportunities like somebody who's younger to go through different treatments, then you know that you have to be very frank, because I don't think that will be like a curative option. But also on top of that, it's not a curative option, but it's not about the doctor or the patient against the leukemia. It's about what you do to maintain some quality of life given the circumstances. I think there's no doubt that it's not going to be the same quality of life like not having leukemia. Very, very few people can achieve this, if any. But we have to think, given the circumstances, what will be the best aim for this patient? And I think that's where the role of the patient is very important, to actually let us know what are their expectations. We can tell them what to expect from the disease. We can tell them what to actually do, how to inform us. But actually, what we need to know what are the main aims. And I think what we did with the Leukemia Care Hub in the hospital at Heartlands before, I think that's where Sally helped a lot the patients to actually get all their thoughts out. And Sally probably worked as a bridge in between like the consultant and the patient, and thinking about things outside of the treatment pathway, outside of the complications. It's about the everyday life of the patient when they're not actually seen by a consultant, when they're not seen by the specialist nurse.
Yeah, so for those who don't know, just listening to the webinar, Sally is our hospital support worker who usually works in Birmingham, but unfortunately due to COVID, she's not currently there, but hopefully she'll be back one day because she's fantastic at what she does. So I hope that explained a little bit of context there, but I agree, people to talk about other than medical things that are related to the leukemia, and are affected by the leukemia, but aren't necessarily things that doctors and nurses need to deal with, are equally as important, and we do our best to support people with those sorts of things. On sort of a related note, Karina, someone's asked us about how they are struggling to keep up with all the terms and the acronyms and the medical language that they come across now they've been diagnosed with AML. I wondered if you could give some thoughts on how you cope with that, and what sources you used to understand these various things, and do you have any advice for the person asking?
Yeah, I would just ask one of your team actually to explain it to you in the hospital. I was very lucky. I think I had a fantastic team who were extremely supportive, and they explained everything to me in a way that made it accessible to me. And also using things like the Leukemia Care website is very, very useful, I've found, during my treatment. I still look at it now because I like to make sure I'm up to date with everything, and I like to keep abreast of what's going on. And just stay off Google, because that is terrifying. However, I think, yes, there is a lot of acronyms and different sort of abbreviations for everything. So I think also when you've got AML, try and just focus on what your particular mutation might be rather than everybody else's as well. Just stay focused on yours, because there is enough to take in with just that, and particularly the sorts of drugs that you might be given. Just focus on that whilst you're going through your treatment, and just minimize the amount of information that you need to focus on. And later on, you might get a chance to sort of go back and learn more about the different types of mutations and drugs and things like that are available. But just keep it to what is relevant to yourself, I think, is the best advice I can give you, rather than overwhelm yourself with too much.
Yeah, that's really good advice. And the person asking describes it as bogging down their consultant. I think it's fair to say that if you're not clear on anything, don't be afraid to ask the questions. It's important you know what's going on. Don't feel like you're bugging people. That's absolutely not what people would, what your medical team would want you to feel like. So carry on, Karina.
Yeah, I just thought I'd also add that always keep a notepad if you're in the hospital as well. Any questions that you have, just write everything down, and then you're actually in a better position when you come to speak to your team to say, oh, I've remembered this question, because sometimes you don't always remember what you want to ask at the time. So keeping notes all the time, because you might wake up at 3 in the morning and think, oh, what does that mean? Or what do I need to know about X, Y, Z? And it's best to just keep that notepad there, and you've always got a reference point then to go back to.
Yeah, that's a really handy tip. Manon, Manos, we've got a question from Facebook about therapy-related AML. They're just asking if you could explain what therapy-related AML is a little bit more, what causes it and things like that.
Yeah, so therapy-related AML is an acute myeloid leukemia that develops as a consequence of a previous treatment with chemotherapy. And this previous treatment with chemotherapy can be because of solid organ cancer, so because of breast cancer, it's quite common, or sometimes for hematological disorders like Hodgkin's lymphoma, treatment with ABVD, but also other treatments like the old-fashioned treatment of chlorambucil, for example, used for like different low-grade lymphomas, and CLL as one of the first drugs actually has been used for CLL. And these particular drugs do cause a significant sort of disorder of the bone marrow, a significant drop in the counts, because the bone marrow starts more or less from an MDS perspective, from a myelodysplastic syndrome, doesn't produce the right quality and the right quantity of cells, and then suddenly starts proliferating in an acute leukemia fashion, because acute leukemia is an aggressive disease. But in these particular situations, it happens because these particular chemotherapies, they do create an abnormality within the bone marrow and starts creating these abnormal blast cells in abundance.
So therapy-related AML is something that it may be a little bit more slower growing initially.
It could be a little bit more slow growing initially, and sometimes it might be difficult to actually pinpoint it. I mean, we had like patients with, as I say, with Hodgkin's lymphoma who had ABVD, and they had a little bit of a drop in the neutrophil count, like a neutrophil count of 1.7 or 1.8, when the low limit of normal in most of the labs is like 2, for example. And then suddenly within 6 months, you can see like the rest of the counts dropping as well, the other cell lines, the red cells and the platelets. And certainly it's a disease different from de novo AML, as we say, because in the de novo AML, there's no predisposing drug sort of related treatment AML, because these are the drugs that alter the DNA to drive the production of these blast cells in the bone marrow.
Okay, thank you for explaining that. I hope that was useful to the person who asked the question. We're coming to the end of the questions from the audience now, so I just wanted to say at this point, if you do have any burning questions, don't let us finish without you asking them. Now's the time to put them in the chat, please. And also on Facebook, please don't forget that you can comment, and we'll be more than happy to take those questions too. I've got a few more questions that areas we could discuss. Manos, I was wondering if you could just explain a little bit more about how long people should expect to be in hospital for treatments, and is that changing at all with some of the newer combinations you're adding onto chemotherapy? Is that extending the time people stay in hospital or perhaps shortening it? Is there any change at all?
So certainly there is a change. I mean, as we mentioned earlier, gilteritinib as a monotherapy, gilteritinib is an oral treatment, and the patients can actually take it at home when they relapse without the need to stay in hospital. So if you see the Admiral trial that I mentioned earlier, gilteritinib versus FLAG-IDA. FLAG-IDA is a treatment that you must have in hospital as an inpatient. It's impossible to do that as an outpatient. Whereas with the gilteritinib, actually you can take it as an oral treatment and being monitored in hospital twice a week, 3 times a week, depending on the protocol. So certainly there is a shift within the relapse setting in the FLT3. If you think about other treatments, for example, like the consolidation in the standard sort of chemotherapy, when patients have DA chemotherapy, let's say that the old-fashioned DA 3+7, and then they have high-dose cytarabine consolidation, depending on the day units. I mean, we tended to give it as an outpatient in the day unit, and you can use different sort of dosing regimens to suit the patients coming like daily in the day unit, and then later on being admitted, because they will be inevitably later on they will be admitted, because they will, about 95, 98% of them will get an infection, will get like a neutropenic fever, and they will need to be admitted. But still, you can shorten the admission by a few days. So it depends on the ambulatory chemotherapy provision that you have as a department. And it depends on the governance that you have about, administering this treatment as an outpatient. Certainly for all the induction chemotherapies, even for venetoclax azacitidine, patient will be kept in hospital for some days. But venetoclax azacitidine, after a couple of weeks, if the patient is stable and the bloods are okay, then you can discharge the patient. Whereas if they start induction with dark chemotherapy or with CPX, it's inevitable that the patient will stay in, because they will have very quickly, they will have the counts down, they will have prolonged neutropenias, then they will have infections. Now, infections are more common on presentation, on disease presentation with AML, but also in the relapse refractory setting. And the relapse refractory setting is probably even the highest risk about getting infections like bacterial or fungal infections.
Just expand a bit more on signs of relapse. So if there's anybody out there who's already had treatment, and you said infections is one of the things that could sort of make you think, oh, this person's AML is returning. Is there anything else people should be keeping an eye out for while they're well that should make them contact their team if they're not sure?
I think there are different symptoms, and sometimes, for example, symptoms like bony pains, for example, which can happen anytime to people that have AML or they don't have AML, but when they have AML before and suddenly they get like really intense back pain that doesn't seem to be relieved with like the painkillers, or they do see like easier bruising, the usual sort of symptoms of presentation, an infection which can be quite bad, having like a high temperature, feeling unwell. These are all things that, or feeling like extremely tired, more tired than they used to be before. Those are all symptoms that can indicate that the counts are dropping. I think these symptoms indicate the fact that you need to speak to the to your team, and you need to be seen very quickly, and you need to have a blood test to see exactly what's happening. It doesn't necessarily mean that all bony pains are AML relapses. Doesn't necessarily mean that all infections are relapses, but all the time you have to exclude this particular sort of shortfalls, because if you leave them out of the equation, sometimes you can be in an unpleasant situation where you let the AML ramping, and when the patients come to hospital, it's too late, or they can have like an ITU admission. I had like an example of one of our patients. It wasn't like relapse, but it was the initial presentation when she went initially to her primary care physician with back pain, was given some Nurofen, went home, pain, she gets some naproxen, doesn't help at all, goes to A&E, is given diazepam in A&E, and the fourth time she comes to the hospital, she actually has a white cell count of 350, and she receives her chemotherapy in intensive care unit. And thank God she is alive, and she's like 5-6 years later now after treatment. But the dramatic sort of presentation and the admission to the intensive care unit, I don't think it's pleasant for anyone.
No, I think there's a balance between remaining vigilant and not worrying too much. I don't know whether, Karina, you want to say anything on that point from a patient perspective. Is it something that you think about, how to balance this in your mind between, thinking of staying well, but also not panicking yourself too much?
That is a difficult just even last week, I had a bit of an infection, and I had to speak to a doctor who suggested I go to A&E just to get my bloods checked again. But I do have my bloods checked every 2 weeks. So it is a constant worry, but I just think trying to look after yourself as best you can and really listening to your body, I think are two really important things to do. Just be very aware of anything that feels different, anything that feels strange, or any kinds of signs. Always checking your body, making sure that you're not looking, you're not getting unusual bruising, anything like that. I do those sorts of things now, just keeping an eye on myself, really. Try and get enough rest and make sure that I can try and maintain my wellness as much as possible. So, yeah. That's
a good point. It must be quite difficult for you to do that. I'm sorry to hear you ended up in A&E as well. Hopefully you're feeling much better now. Manos, we've got one question on Facebook that's quite specific. but I wondered if you could try and address it for us. So somebody's asking if you are aware of a chromosome 10 inversion being in play in AML, and whether it's really rare. Apparently their doctor is not aware of it, and they wondered if there was any information about that particular mutation somewhere.
It's not the commonest mutation. The chromosome 10 inversion is a mutation that happens rarely in AML. It's usually treated as intermediate risk within the sort of ELN specific sort of group, the risk group. So I don't think that there's anything in particular within the chromosome 10 mutation. There's no indication that it is in the adverse risk, but there's no indication that actually it's in the good risk. And I think that's because of the rarity of the abnormality. And I think that's where it's important to get all these sort of trials and all the samples analyzed and ongoing about understanding even like the rarest mutations, how they affect patients. But I think generally with the patients that have been seen with this mutation, I don't think that there's anything in particular to suggest that it is within the adverse risk group.
Great, thank you. I hope that was helpful to the person listening. If you've got any more questions, get in touch with us and we'll try and help you answer those questions with your doctor. I wanted to let Karina have the last word, and then I think we'll wrap up at this, your last chance. Anybody who wants to ask questions, I think I've answered all of them in the chat. Karina, I wondered if you could say a bit about how you looked after yourself during inpatient treatment. I think that's one of the most difficult times for AML patients. And do you have any tips to leave people with who might be listening today, who are in hospital and wondering how to keep themselves as happy as they can be, I suppose, during that time?
Yeah, it is a really difficult time, the in-hospital treatment. And I did find the hospital food wasn't particularly nutritious. So it's always good if you can get people to bring in, say, something that's easily digestible for you and that you like to eat as well, because then you'll be more inclined to eat it, especially if you are struggling with food and you can't really keep things down and your appetite isn't very good. Also, try and exercise whenever you can. I was very lucky. I had a physiotherapist come around and visit me frequently. So she gave me some little exercises to do with one of those sort of stretchy bands and things. And that was very, very helpful, and gave me a little focus every day to just make sure that I exercised a little bit, or when I was able to go for a walk around the ward, use the exercise bikes, little things like that will just help your physical confidence as well, that you can sort of help yourself a little bit. And I found it very difficult to read books or concentrate at all because you're so unwell, and people give you a lot of books, which is very kind. However, I read them a lot later. I found the radio, listening to the radio or listening to podcasts, and some colleagues actually gave me a small gaming device, and it's not something I would have done before. However, it was actually quite relaxing, and some people took up knitting, doing things like that just that are quite sort of calming and meditative things, but don't require a lot of concentration, because I think you really need a lot of energy for the treatment itself and keeping yourself as well as you can during that time. And don't be afraid to ask the nurse when you need anything at all. Just hit that buzzer, if you need some more water, if you need some more protein shakes, if you just want someone to talk to, that's what they're there for. And I think that, they're wonderful people. And so that's one way to help keep yourself sane as well. Just chat to people as much as possible if you feel up to it as well.
Definitely some really good tips there. To the person who just asked a question, we are going to end now, but I will make sure we follow up with any questions we've missed. So apologies for missing that one. So just to end off today, thank you to our panelists. You've been really fantastic and some great perspectives. Lots of information. If anybody wants to watch the webinar back to try and digest some of the medical content, perhaps, we will be putting a recording up online and sending it around to everyone who attended. So you will have that afterwards. Could we make the slides full screen if possible? Thank you. No, I'm thinking, it's my computer being slow. Thank you, Nick. So we just wanted to end by reminding you of all the different services we've got here at Leukemia Care. So more of these webinars, we're trying to do at least a couple every month. So keep an eye on the website for future ones. If you're not signed up to our newsletter, probably the quickest way of knowing about what we've got going on. So I would encourage you to do that. Again, you can do that on the website. We do have a podcast, as Karina mentioned, podcast just then. Ours, I think on the next slide, I've got a little bit more information about the podcast. I'm the host of the podcast, and we put out an episode every month. They're just stories around, just telling patient stories on the is what we do on the podcast. It's a nice way to hear from other patients, which is particularly valuable for most people. If you want next slide, please. And then if you're looking for any support, we have lots of ways you can get in touch with us by phone, using the internet, or via WhatsApp as well. We're still running our support groups virtually. We have a welfare advisor if you're looking for specific advice around finances. If you need any help understanding sort of clinical trials, and we've mentioned a few of those things today, we can help you with that through our advocacy services. And then the last particular service I wanted to mention was the Counselling Funds. If we go to the next slide, please. So we have set up a fund to provide up to 6 sessions of counselling for those of you who may not be able to access this through your hospital or things like that. So please do get in touch if you think you need this kind of support, and we will sort you out as best we can with the fund. And the final slide is just a reminder of how you can get in touch, which we will leave up while I finish up the webinar. Thank you again to everyone who attended. Thank you to those on Facebook for watching. Thank you to Manos for an excellent presentation and answering the questions. And to Karina for offering her experiences. It's a really important part of our webinars, and we really appreciate it. Thank you everyone for your time, and have a lovely... Goodbye everyone.
Thank you.
Bye.